Thank you, Kara, for giving me the opportunity to fill in for a grand rounds. Doing the grand rounds after New Year's is always tricky to to get someone to come and chat, and I'm more than happy to fill in at a moment's notice. And this morning, I was going to very informally discuss neuromodulation for epilepsy, and it's something that a lot of people already know about, and a lot of people have had some tremendous amount of practice, taking care of patients who've had various forms of neuromodulation, whether it's a vagal nerve stimulator, deep brain stimulator, responsive nerve stimulator. And I was just going to briefly talk this morning about neuromodulation for epilepsy and just give everyone an overview. Neuromodulation for movement disorders, which is something Dr. Michael Kruger has a lot of experience, Dr. Poonambadia has a lot of experience in, is a totally separate topic and one I'm happy to chat about in the future, but in and of itself probably deserves a solid 45-minute discussion when it comes to deep brain stimulation for dystonia, for instance. So at any point in time, please don't hesitate to interrupt me if you have questions, or throw them in the chat box. And Christine, if you don't mind letting me know that there's questions in the chat box, and I'm very happy to address them in the moment. These are my relevant disclosures. I've been a long-time consultant for Medtronic for their neuronavigation division. Really won't have any overlap with anything I'm going to chat about today. And BK Medical is an ultrasound company. And the other credit that I want to give is my old partner, Dr. Hannah Goldstein, and I both had given versions of this lecture over the years. So I always like to give credit where credit is due. Several of these slides are terrific slides that Hannah had put together, and I have shamelessly commandeered and used over the years. And so this is what we were going to chat about today. And I don't think it's going to be more than a 30 or 40-minute lecture, but I tend to get a little long-winded. If I get in the full-on loquacious mode, please stop me. We're going to talk about an overview of neurostimulation for epilepsy. We'll talk about the FDA-approved neurostimulation devices. We'll talk about efficacy in AE. We'll talk about surgical perspective, and then we'll just wrap up with a couple summary slides. Again, anytime a surgeon gives an epilepsy talk, we have to talk about refractory epilepsy because it really defines the patient population that we're chatting about this morning. The long and the short of it is the landmark study by Kwan and Brody in 2000, suggesting the natural history of epilepsy once a child has failed 2 appropriately dosed and tolerated anti-seizure medicines. The likelihood of achieving seizure freedom with any medical therapy is less than 5%, and escalating therapy beyond the 2 anti-seizure medicine threshold likely will serve as a delay to definitive epilepsy treatment, which in this case is epilepsy surgery. So really, 2 appropriately dosed and tolerated medications, if a child is continuing to seize, is not at 0 seizures, please, they should be referred for an epilepsy surgical evaluation, because the likelihood of ending their epilepsy with additional medical therapy is less than 5%. If on MRI, a child has a lesion, they are lesional as far as their epilepsy is concerned, the chances of additional medical therapy achieving 0 seizure is even lower. There's a lot of work that demonstrates that, going all the way back to Spooner in 2006. And again, if we continue to escalate therapy, medical therapy beyond the 2 anti-seizure medication threshold, there could be suboptimal seizure control, and there could be unacceptable neurological morbidity or even mortality in the form of sudden unexplained death secondary to epilepsy, what we call SUDEP. So again, I know I can't put too fine of a point on it, but a failure of 2 appropriately dosed and tolerated anti-seizure medications to achieve seizure freedom is considered refractory epilepsy, and a seizure-free duration that is at least 3 times the longest seizure interval prior to starting a new intervention would need to be your definition of seizure freedom. So in other words, if a child seizes every day, they need to be a year seizure-free to be considered seizure-free. But if they seize once every 3 years, they would need to be seizure-free for 3 years before being considered free of epilepsy. So that's our seizure freedom definition. Why do we choose epilepsy surgery in children who have refractory epilepsy? There's a variety of very compelling reasons. Going back about 20 years, we've observed that intellectual dysfunction in the form of an IQ less than 79 can occur in over 60% of children with uncontrolled unilateral temporal lobe epilepsy. We know that independent of pathology, intractable epilepsy in the first 2 years of life can be a significant risk factor for intellectual disability. We know that inadequately controlled seizures can result in what we call the epileptic encephalopathy, which is impairments of cognition, language, social skills, and communication. We know that suboptimal seizure control results in poor psychosocial outcomes, lower quality of life, lower rates of high school completion, lower rates of employment, lower rates of domestic partnership, lower rates of overall socioeconomic productivity. And then if you sort of ask the quality of life questions of teenagers with epilepsy, it's going to be peer-peer interaction, lower rates of self-worth, lower rates of athleticism. It really impacts every domain of a child's life who has intractable epilepsy. As many on this call are very well aware, we have a fantastic multidisciplinary epilepsy program here at Phoenix Children's. It's very similar to the one that exists at most tertiary and quaternary pediatric centers. And we are an NAEC certified center, which means that we supply all the different services that are required to take a child from the diagnosis of medically refractory epilepsy through the epilepsy surgical pipeline to the end result, which hopefully is seizure freedom or palliation from seizure. It all begins with the Interdisciplinary Epilepsy Surgery Conference, where we obtain electrophysiologic data, imaging data, neuropsychology, and we use that to try to hypothesize where we think the seizures are coming from so that we can target an intervention towards it. And we decide in that conference whether we think seizure freedom is a goal or whether we think seizure reduction is a goal based on focality, based on whether or not there's a genetic etiology, based on whether or not we think there's a potential curative option. I think in the end, strategy is tailored to the patient. We know that about 1/3 of epilepsy patients may become intractable over time. Cure is almost always the goal at the outset. We try to consider every child for cure, but not every child can be considered for a cure. And when curative options are not possible, it's usually due to a variety of reasons. It could be that we can't localize the epilepsy to just one focus or brain region, or we can, but we can't resect or disconnect that particular region. What would be an example of that? An eloquent cortical region, Broca's, Wernicke's, primary motor in an older child, an area where we don't want to create a deficit that would be life-altering for the child and unlikely that the child could recover from. Genetic, syndromic, and generalized epilepsies, those are kids that we've traditionally almost always considered for VNS as a first-line option, or even if they are potentially a curative patient, for whatever reason, the family doesn't want brain surgery for cure. They're not interested in the disconnection or resection. And I know Angus and I definitely share a couple kids who, despite being excellent surgical candidates, the families are very reluctant to have a curative option. And those can be very challenging discussions to have because as neurologists, as neurosurgeons, as pediatric subspecialists, we really have the best interests of the child at heart and in our mind. And sometimes it can be really challenging when there's barriers, whether or not it's cultural or language or, religious or, educational or understanding that keep us from delivering what we think is potentially the best option to the patient. But so, that happens not infrequently, and we have to navigate that. So when cure is not necessarily the goal, and we're looking at palliative options. In essence, in the neurosurgical, lexicon, palliation means to us make life better, reduce morbidity, reduce mortality secondary to epilepsy. And in that bucket, we have a few different options. Callosotomy has been around really since the 50s and 60s. The way we do it now is a little bit different than the way it used to be done. We still sometimes do it the way it used to be done, but fundamentally that hasn't really changed much over the years. And then we have what we call the newer iterations of palliation, which are neuromodulation or neurostimulation strategies, of which vagus nerve stimulation has been around for a long time now, FDA approved in children for close to 20 years. Responsive neurostimulation and deep brain stimulation. Deep brain stimulation has been around for over 20 years too, but hasn't been traditionally used in epilepsy and is not FDA approved in children for epilepsy, despite the fact that we do it. And responsive neurostimulation, which has been around for, I'd say, about a decade in routine use. And again, was not initially designed to be used in children, though it's being used more and more in children today than ever before. So if you look at sort of the 3,000-foot view of the variety of neuromodulation techniques for epilepsy, these are not all being used in the US, and they're not all being used therapeutically under, in FDA-approved circumstances, but they all do exist. We have both invasive and non-invasive options. We briefly talked about VNS, DBS, and RNS, which are surgical invasive options for palliation for epilepsy, but there actually are a variety of non-invasive options that have not made their way to routine use in the United States. Trigeminal nerve stimulation has been around since I was a resident. We actually did studies of it at UCLA. It was initially recommended for both in the research world, recommended for use in depression and for use in trigeminal neuralgia. It's still being studied in those particular realms. There have been people who have tried studying in epilepsy as well. It's essentially pads that are placed on the trigeminal nerve distribution and retrograde neurostimulation is performed. Perhaps one of the more fascinating ones, it's been in Germany and I think Western Europe for quite a few years, has not made its way to the United States, is transcutaneous vagus nerve stimulation, which is exactly what it sounds like. It's neurostimulation that occurs superficially over the vagus nerve. RTMS, which I think we're going to have the capability of doing here, hopefully in the near future. It's being used in some circles therapeutically in addition to diagnostically. We're not necessarily looking at using it this way initially here at Phoenix Children's, but there are some that suggest that it could be used therapeutically for epilepsy. RTMS really has found its home diagnostically for things like language mapping, motor mapping, and then therapeutically for psychological disorders like depression. And then transcranial direct current stimulation, which again is not really is not in routine use in the United States. You can also separate neurostimulation strategies as closed loop and open loop. Open loop is essentially neurostimulation that's agnostic to what's actually occurring at the neural level. So it's not requiring any kind of feedback. It's just providing stimulation like a pacemaker. And then closed loop. And closed loop is where you get feedback from what you're stimulating to help guide stimulation. And the prototypical example of closed loop stimulation for epilepsy is RNS. There is closed loop deep brain stimulation that's not in routine clinical use yet, though the percept can act in some ways as closed loop. There is such a thing as closed loop VNS, but it's not something that we do here in the United States that LivaNova provides. So, brain stimulation. The mechanism of action of brain stimulation is still not entirely elucidated, though I think we have our ideas. We think that electrical stimulation enhances inhibition and frequency modulation to interrupt seizure onset. We also think that electrical stimulation alters the epileptic network. It actually changes the network itself through stimulation of critical network locations like the vagus nerve, the thalamus, and the basal ganglia, which is why thalamic neuromodulation has really been, I'd say in the last 5 years, the most talked about neuromodulation strategy in both adults and children who are not potential candidates for a curative option. Despite the fact that vagus nerve stimulation has been around for over 20 years, and Angus, please correct me if I'm speaking out of line, but I'd say we still don't entirely understand how and why it works. We think it's a widely distributed network that is essentially retrograde through the vagus nerve, through both deep brainstem and thalamic nuclei. But I would say that it's interesting that we have something that's been widely used in practice for over 20 years, and yet we still don't. Not only do we not understand how it works, but we can't predict response rates non-invasively prior to implanting the device. For FDA-approved devices here in the United States, there are 3 neuromodulation therapies approved for refractory focal epilepsy. VNS has been approved since 1997. The CNT trial, which was the landmark trial for deep brain stimulation of the anterior nucleus, has led to FDA approval in 18 and above since 2018. And then closed loop responsive neurostimulation of really 2 foci, which is what RNS was initially intended for, has been FDA approved since 2013, also in 18 and above. If you look on the right-hand side, these are pictures of various devices. On the top, you have the Activa, which now comes in both rechargeable and non-rechargeable options. You had the Sentiva, which is the Model 1000, which is the most current of all the VNSs. It's the smallest as well, and I would say has the most robust options for programming. And then in the bottom right, you have the responsive neurostimulation device, which right now, the only RNS device in the market is made by NeuroPace, and it allows for two leads to be placed, and a total of 4 channels per VNS. So the mechanistic theory behind VNS is that there are hyperexcitable brain regions that can be modulated through the brainstem, through the nucleus tractus solitarius, and then its downstream projections through the limbic system and the thalamus. And I think there's a lot of hand-waving that goes on as far as exactly how this network functions. There's a lot of interesting work being done actually at Sick Kids by George Ibrahim to try to understand how to predict responders. He has a multi-center study that we participated in Seattle, in which we're providing both retrospective and prospective data to try to understand if there's a way that we can potentially predict, either based on resting state functional connectivity. He's also played with PET scans as well to try to figure out how do you predict who responds and how well do they respond. It's FDA approved as an adjunctive treatment of drug-resistant partial epilepsy in patients older than 4 years of age. Of course, we've used it in less than 4 years of age, but FDA approval is 4 and above. It's been used in other countries for all ages, for all seizure types, and it is by far and away the best studied and most widely used in the pediatric population. This is a paper I wrote as a resident, and I just wanted to show you the pictures of how we place the vagus nerve stimulator. I'm sorry for those of you who have to be subjected to graphic photos before you've had your first cup of coffee. This might wake you up some for clinic. But essentially, it's 2 incisions, one on the neck, one on the anterior chest wall. The incision on the neck provides for a corridor for dissection down to the vagus nerve. The vagus nerve sits in between the internal jugular and carotid arteries and the carotid sheath. So basically, we cut down medial to the sternocleidomastoid. We pull that laterally. We open the carotid sheath. We dissect out the vagus nerve, and we place 3 coil leads around the vagus nerve. For those of us on the call who've performed this surgery, almost everyone will agree that the most tedious part of the whole surgery is getting the actual coil leads onto the vagus nerve. We usually reserve that for our residents and fellows. Thank you very much for your service, our residents and fellows, for putting the coil leads on. And then we typically will put a strain relief loop in the neck so that as a child grows or as they vigorously move their neck about the axis of the neck, that they don't break or dislodge or pull on the coil leads. So that's what we call a strain relief loop. And then it's connected to the generator that sits in the anterior chest wall, usually, but not always, above the pectoralis, superficial pectoralis, and below the soft tissue of the anterior chest wall. Globally speaking, it achieves about a 50% reduction in seizures in about 50% of children. Most studies have been observational, non-randomized, open-label studies. We think that implanting young children with refractory epilepsy can be very beneficial if they don't have other surgical options, because less seizures does seem to be better for the developing brain. We can get into that at the end. Only about 5% of children or less, some people will say 1%, will be seizure-free with a vagal nerve stimulator. And I know Angus has quite a few children he's mentioned over the years who've had great benefit from vagus nerve stimulation. This is the overall efficacy chart that a lot of us will refer to. And if you look, there is a suggestion that the response rate goes up the longer that children are implanted. And it is one of the few options for epilepsy where the efficacy does seem to increase the longer the child is implanted. There might be a 7% increase in efficacy over 2 years of implantation. That was an article that was published in Neurology. But you can see that essentially the median decrease in seizure frequency seems to hover in the 70% range in about 50-ish% of responders the longer you get out. It seems that pediatric patients do better with VNS than their adult cohorts, which is an interesting finding. This is Dario Anglo at Vanderbilt had published this now about 15 years ago, suggesting that the time, as you look at time post-implant, that children in particular seem to do better than those over the age of 18. And I cannot remember the number of patients that was in this study, so I apologize for that. It also seems that depending on the seizure type, you can predict more or less what the response will be. With VNS, it appears that the greatest response is with auras, and that the lowest rate of clinical response were among patients with either primary generalized or secondary generalized tonic-clonics. In fact, generalized tonic-clonic seizures were negatively predictive of clinical response to VNS at 1 year, and patients with other generalized seizure types, including atonics, responded to therapy in more than 57% of cases by 1 year. This is also at a Dario study. For VNS and LGS at 1 year of therapy, there's a median decrease of somewhere between 60 and 70% in seizures and a response rate of about 60%. Excuse me. In those without LGS, the seizure decrease is about 55% with a response rate of 52%. And interestingly, in children with epileptic encephalopathy, they seem to actually have a better response than those without epileptic encephalopathy. So VNS can be a very effective tool in children with LGS and epileptic encephalopathy. So it's something to keep in mind. I mean, to me, VNS is really an option for any child with intractable epilepsy, but it seems to do really well in LGS and really well in children with epileptic encephalopathy. When you look at studies that have compared VNS to callosotomy, what you see more or less is that atonics seem to do really well with callosotomy. And when I look at what we do in Epilepsy Conference, I think we think about atonic seizures as being the unique category that helps us decide whether we want to go the VNS route or the callosotomy route. Atonics are terrible for children. Instantaneous loss of muscle tone can lead to craniofacial injury, lacerations, fractures, repeat visits to the emergency room, head injury, subdurals. inpatient admission, that kind of stuff, surgery. And so we really want to target therapy to eliminating atonics. And calisotomy does really, really well for that. Greater, than 80% will have a greater than 50% reduction in atonics following calisotomy. Whereas for VNS, it tracks about all the different results of VNS, which is about 55% have a greater than 50% reduction in their atonics. The one that has always, I think been less clear, and I'd love for my colleagues in neurology to comment on, is the role of VNS in myoclonic epilepsy, and we could possibly talk about that at the end. I mentioned briefly how we place the VNS. I won't spend any more time on that. VNS adverse events are usually very manageable and fortunately pretty uncommon. When we counsel patients for vagal nerve stimulation, we talk about that tickle in the throat that a lot of kids can get, or the change in the tenor of their voice, what we call hoarseness, that usually is limited to a couple months after implant and then goes away. There are rare instances of dysphagia, and sometimes it can be severe. Sometimes it can result in G-tube placement, but fortunately that's very uncommon. It's somewhere between 1 in 50 to 1 in 100 children that can suffer significant dysphagia. Other things like neck pain, paresthesia, sleep apnea. Sleep apnea is something we consider with vagus nerve stimulation, but now with the Model 1000, you can alter stimulation between evening and daytime. And so I think VNS isn't really as much of a worry in kids with sleep apnea as it used to be. Those children who are rapid cyclers require their battery being replaced pretty quickly, sometimes within 1.5 to 2 years, if they're, at a high output current and they're just very rapidly cycling through batteries. For the interest of time, I mean, I could skip, I guess we can just briefly mention like a prototypical example of a great VNS patient, an 18-year-old female with prenatal stroke and intractable epilepsy, seizure onset at 7 years, multiple seizure types, independent left and right ictal discharges, near continuous epileptiform discharges on one side, had the VNS at 10 years of age, seizure-free, 1 year after VNS, and weaned off some meds. Obviously, results not typical, less than 5% of children will be seizure-free with VNS, but I think this is a pretty typical example of the child that we consider VNS for. Any questions so far before I move on to deep brain stimulation, or any comments that anyone wants to make on vagus nerve stimulation? Yeah. Are there anything in the chat box, Christina?
No, there's nothing in the chat box.
Okay, great. I'm stunning everybody. I'm killing it. The next topic is deep brain stimulation. So this is where it gets a little more exciting to what I call the more cutting edge techniques. DBS involves, so open loop in particular, involves predetermined programming of electrical stimulation to deep brain structures. It's 2 implanted electrodes connected to a generator, a pulse generator that's implanted in the chest, similar to VNS. I find the history of DBS and epilepsy to be particularly fascinating. The description of central median nucleus thalamic stimulation is not new. It's been around for over 20 years. In fact, in France and in Mexico, they've been publishing DBS for epilepsy probably about 15 years longer than everybody else. In some large series too, the Velascos in Mexico City in particular, and then Jean Regis in France, both have amassed large series of DBS back when I was a resident, and none of us were doing DBS for epilepsy in the United States then. We didn't even start doing DBS for epilepsy until the Santee trial, which was published, I want to say, in like 2011, 2012, and then led to FDA approval for anti-DBS in 2018. Generally speaking, DBS is indicated in children greater than well, in adults greater than 18 years, drug-resistant epilepsy, focal onset seizures unsuitable for resective surgery. The mechanism, like everything else, is not completely understood, but it's thought to disrupt networks involving seizure propagation. The ANT nucleus in particular is an important node in the limbic circuit of Papez. Stimulation of the ANT and of the central median thalamus can both produce the generalized responses on scalp EEG and reduce interictal discharges, which really makes us think that modulating those areas of the thalamus can actually modulate diffuse network activity in the cortical surface. And so the idea behind deep brain stimulation is that you're creating a functional reversible lesion of an epileptic node, of a node in the network. And so using this functional reversible lesion, you can modulate diffuse epileptic networks. You can possibly prevent seizure initiation or prevent seizure propagation. And so that's sort of the idea that underlies thalamic DBS. By far and away, the best studied thalamic target is ANT. And in the sentinel studies of ANT-DBS, there's about 40 to 70, 80% reduction in seizure propagation and generalization, and a lot of work has been done on ANT-DBS, really in limbic epilepsy. So in sort of the adult epilepsy centers, ANT-DBS neurostimulation is considered for instance, bitemporal epilepsy. That's a prototypical example in which ANT-DBS will be considered. In the landmark Santee trial, it was about a 60% reduction in about 50%, 60% of patients. We'll get into that in a second. So the anterior nucleus of the thalamus projects to both superior frontal and temporal lobe structures, and it's commonly thought of as the limbic epileptic network. And interestingly, in laboratory models, if you look at the traditional chemically induced epilepsies, PTZ, canic acid, kindling, anterior nucleus neurostimulation seems to work in those laboratory models, the basic science laboratory models of epilepsy. So like I was alluding to in the Santee trial, this was 110 patients who had focal or focal to bilateral tonic-clonic seizures. At about 3 months, there was about a 40% seizure reduction, 25 months, 56%, 37 months, almost 70%. And then in the long-term data, about 7 years, there was a 75% reduction in seizures in patients who were implanted. Other benefits that were noted in that trial included improved quality of life, cognitive improvement, improvements in mood, and a reduction in medication side effects. Other factors in the Santee or in analyses of ANT stimulation, other factors that have been associated with efficacy in ANT neurostimulation include an absence of structural abnormalities on MRI, particularly in ANT and hippocampus, and what we think is reasonable electrode targeting within the ANT nucleus. We think that ANT neurostimulation works best for deep temporal or limbic seizures. We think that CM thalamus neurostimulation works better for generalized epilepsy and Lennox-Gastaut. And if you look at, there's some really neat white matter tractography that Mark Richardson's lab up in Boston has done, showing really the diffuse white matter networks that emanate from CM thalamus. It's actually quite striking. It really interconnects with very, very large diffuse cortical brain regions. The Estelle trial is still probably the best trial that we have to date, though there is a large NeuroPace trial that's enrolling for CM neurostimulation, but this is for DBS. The patients were 15 to 65 years old with a mean age of 28. There were 19 patients included. This was central median thalamic neurostimulation. At 3 months in the stimulation group, there's a significant reduction only in seizures on EEG. And then by 9 months, there was a 50% reduction in seizures. The CMPF is widely connected to a large variety of brain regions, widespread frontal, insular, basal ganglia projections. A smaller study by Velasco et al. In 2006, they implanted 13 patients ages 4 to 22, all had generalized epilepsy, all had seizure reduction by 6 months, and by 18 months, they noticed an 80% seizure reduction with only 3 patients who were non-responders and 2 patients who were completely seizure-free. The DBS surgery is about a 4-hour surgery. We do it frameless with the robot, but it used to be done in an Lexel frame. Essentially, it's 1 or 2 incisions on the top of the head in front of the coronal suture in which you target the thalamic nuclei. A&T tends to be a little bit trickier to target than CMPF because with A&T, the ventricles can be in the way. So sometimes you got to come low and lateral without going through unless you want to go through the ventricle to hit the A&T nucleus. CMPF is a little bit easier. There you can come a little bit more posteriorly and even medially to hit the CM nuclei. And essentially the leads are placed through 2 incisions up here, 2 small burr holes, and then they're tunneled behind the ear to the pacemaker that again is placed in the anterior chest wall. Typically, this is a 1 to 2 night stay in the hospital and go home. Adverse effects from DBS are very unlikely. The risk of significant hemorrhage requiring a reoperation is less than 1%. Infection is 2%. Lead migration or malposition is very low. And, the rest of the A's listed here are very uncommon. A classic example in the pediatric world for DBS, this was a 14-year-old female who had refractory left frontal lobe epilepsy, focal and generalized discharges, myoclonic seizures, had a series of resections which did not provide seizure freedom, had a VNS with limited benefit, had another operation to extend the frontal lobectomy. None of that seemed to work. Eventually underwent DBS and CMPF. I did this back in 2020 when she was 13. And actually has had, I think, greater than 80% seizure reduction with no generalized tonic-clonic seizures. Before I left Seattle, we published our series of DBS and LGS, which I don't have mentioned in the slide deck here. I can't remember what journal we published it in. I want to say Child's Nervous System, but I could be wrong. But anyway, it shows about a 70% reduction in seizures across all patients with LGS. We only had 1 non-responder. I'll close up with responsive neurostimulation, what goes by the trade name of NeuroPace, which right now is really the only closed loop option. For those of you who've seen it or programmed it, this is what it looks like. You have the option of a cortical strip or a depth electrode connected to a generator implanted in the skull. The idea behind RNS was based on the observation that delivering stimulation can abort after discharges during electrical stimulation for functional brain mapping. So that's where RNS came from. And it turns out that further research has suggested that not only can you abort seizures by providing network stimulation, but you can actually likely alter the plasticity of epileptic networks. You can retrain them or entrain them, so to speak, through stimulation. RNS is not FDA approved in children under the age of 18 as of yet. There is going to be probably a revisit of that in the near future. There's a lot of work trying to acquire 12 to 18-year-old children in aftermarket surveillance, what we call phase 4, for potentially an alteration of labeling, but that has not occurred yet. NeuroPace fundamentally, monitors electrocorticography. They have their own proprietary algorithm for how they transform signal over time. But essentially, you can program thresholds to which it responds to, and then they can record and report data. You can implant, one thing I would mention is that you can implant as many leads as you want, but you can only record from 2 separate leads at any given time. And so some people have suggested doing a surgery where maybe you implant more than 2 leads if you think it's medically indicated. And if the 2 leads that you're recording from are not effective, you can then take the child back to the surgery and change the leads that are implanted into the generator. Though I would argue that you're taking them back to surgery anyway, you can just implant the leads later. But that whether you do it up front or whether you do it later on, that is an option for children who you think may have focality that requires more than 2 leads being placed. Essentially, the detector, the sensor for RNS, monitors signal intensity, changes in frequency, and discharges within specified frequency ranges. And that's how it identifies epileptiform activity. And it applies electrical current directly in response to that. It may also function by suppressing cortical synchronization, potentially even in regions that are far away from where you implanted. And that's where we think it may be in training neural networks. The indications for RNS are patients greater than 18 years of age, refractory to greater than or equal to 2 medications, with partial onset seizures, 1 to 2 foci. Back when I first started implanting NeuroPace in like 2014, 2015, really it was prototypically a bitemporal. Like it was an adult with mesotemporal epilepsy, bitemporal epilepsy. And I think that's still the best studied subgroup for RNS because that is a very prototypical 2 identified foci for epilepsy. Since then, though, indications have expanded tremendously. Frontal, occipital, parietal, PVN, paraventricular nodular heterotopia, tuberous sclerosis, children with, 2 foci or more. And I'd say in the last 5 years, perhaps the most exciting for RNS, just like DBS, has been the thalamic application. And so a lot of centers, including ours, have been implanting centromedian thalamic nuclei, pulvinar thalamic nuclei with RNS with very reasonable results in kids who have both focal and generalized epilepsies. And we can definitely get into that. It's certainly not FDA labeled for these things, but the efficacy is there. Like DBS, RNS seems to work better the longer it's left in place. You can see the responder rate and median % reduction both increase over time, up to the 50 to 60% median reduction. And if you actually follow them out all the way, like DBS, there's about a 75% median reduction in seizures, and about 35% of patients can get a greater than 90% reduction in their epilepsy with RNS, which is substantial. I mean, that is a very impressive efficacy. And if you look at DBS too, DBS also probably long-term 7 to 9 years out is a greater than 75% median reduction in epilepsy. About 28% of patients had about a 6-month or longer period of seizure freedom with RNS as you got further out in long-term data. So I think this is worth just kind of staring at this chart for a second and seeing how impressive, at least in my opinion, long-term data is with both RNS and DBS. Again, just kind of comparing year 1 to year 9. In the real world study, again, 82% at 3 years, 67% at 1 year. I think the most compelling potential argument for palliative procedures like RNS is that not only does it reduce the number of seizures, which can improve quality of life, improve caregiver burden, days lost to work, trips to the hospital, status epilepticus, all that stuff. There is hard evidence that it reduces SUDEP risk. And I think, the most compelling argument for brain surgery for epilepsy is the reduction of SUDEP risk. And so in patients who got RNS, there was a significant reduction in SUDEP risk following RNS. And then, of course, quality of life. So if you look at anything from using the QALY to looking at, the subdomains in the QALY, cognitive, mental health, physical health, they all improve with RNS, all improve compared to baseline. Like I sort of alluded to, RNS originally was developed for neocortical targeting, but now is being used for deep brain targeting like DBS. I myself have implanted, and our team, have implanted CMPF, Pulvinar, ANT, for the right patient that can result in significant seizure reduction, improved quality of life, and reduction in SUDEP risk. The surgery, as I described earlier, the generator, unlike DBS and VNS, is not placed in the chest, it's placed in the skull. There are some benefits to that, particularly with regards to lead breakage and lead, migration. The skull itself is either hollowed out or a craniotomy or craniectomy is performed, and there's a cradle in which the generator sits inside the skull. So it doesn't touch the brain surface or the dural surface, it sits right on top of it. And then the leads are placed very similarly to a DBS using the robot for deep brain structures or small burr holes where you slide cortical strip electrodes on brain regions of interest if you want larger, like surface neocortical coverage. Usually that's a 2-night stay, and the battery lasts somewhere between 7 to 10 years. This is an example of sensor-median nucleus RNS. This is from my prior practice. This was a 13-year-old male with LGS and autism, seizure onset at 2 years of age, multiple seizure types, myoclonic absence, GTCs, atonic, so on. Failed 15 different ASMs. Had the VNS, really didn't seem to do a whole lot. Had a callosotomy, which stopped the atonics, but not any of the other seizure types, or in the GTCs, but not any of the seizure types. Had a completely normal structural brain MRI other than some volume loss in the years of epilepsy. And we did see him thalamic RNS. Here's an example of the seizure being detected in the right side. This child had long-term efficacy, significant reduction, 50-60% reduction in seizures over the long term. If you compare all the palliative techniques side by side, I would say overall complications are low, infection, hemorrhage, low rates of these, significant reductions in seizures at 3 months and at long term, 60 to 70% is what I quote patients, generally speaking. Seizure freedom, it depends on the study you look at. I generally tell patients we can't guarantee seizure freedom, but there's a small percentage of patients over the long term who may be seizure free with any of these techniques. I think the seizure freedom rates may be a little bit higher for DBS RNS compared to VNS, but overall, I just tell patients that's not why we do it. We do it to reduce seizures with the hope that maybe a small percentage might be seizure free, or at least have long interseizure intervals or long periods of seizure freedom in between intervals of seizures. Again, this is just another chart comparing RNS, ANT, DBS, and VNS with regards to seizure frequency and responder rates. And again, this is probably my favorite chart, which shows SUDEP reduction. And I think the point I would just make is that all three, VNS, DBS, and RNS, reduce SUDEP risk. And that is a very compelling reason to do it. And I would close with just a couple remarks. Neuromodulation is non-destructive. It's functional lesioning. It is certainly the future. The future is here. It's being done all over the country, all over the world. The FDA is a little bit behind the clinical practice on this one. I sit in all these, I know I know Kevin and Corwin and Angus and Rhonda, you guys go to the meetings and you see that this is being done, everywhere now. And I sit in these working groups where we talk about this. There's a lot of struggle right now around payers. The payers haven't caught up because of FDA approval issues, but we all have strategies for getting around that. The companies are very well aware of this and are working with centers to get approval for patients for implants of both DBS and RNS. But I think, what I really want to say, not only as an epilepsy surgeon, but just as an advocate for children with intractable epilepsy, all children with intractable epilepsy have an option, have a surgical option that is better than medical therapy, whether it's VNS, RNS, DBS, resective options. There's just, a lot of different options for children with refractory epilepsy. Children who are traditionally not considered epilepsy surgery candidates, LGS, generalized genetic, send them to us because they can definitely benefit. They can benefit from VNS, they can benefit from DBS or RNS, depending on how aggressive their families want to be. We have a lot of, menu options on the palette, so to speak, for them to choose from. I think neuromodulation is only going to improve in time. Signal detection and processing, these are really just computer bioengineering problems that can be solved. And I think they're going to be solved in the near future, and AI is going to be very important here. Optimal treatment parameters, the more patients we implant, the more we treat, the better we get at figuring out what the optimal treatment parameters are. The devices themselves mechanically are going to just improve in time. They're going to get better lifespan batteries, more channels for input. They're just going to be more complex and intricate, better predictive algorithms, and improved knowledge as to where to put these devices, where we localize, where we get the best responses from, maybe where, for instance, in thalamic targeting, where specifically in the thalamus we have optimal targeting. There have been some papers to suggest there is somatotopy within all the thalamic nuclei, and so we need to just kind of better target within those, somatotopic areas. That's something we got to figure out. Improve quality of life, reduce SUDEP risk, are all benefits that we get out of palliative procedures like neuromodulation, and perhaps we can even lower doses of medicine or get patients off medicine completely. And with that, I will stop talking and open it to thoughts, questions, musings, suggestions. Thank you so much for letting me chat with you today. I appreciate it very much.
Hey, Jay, great talk. This is Michael Kruer. Had a question for you. In terms of trying to choose between RNS and DBS for a particular patient, what are the factors that might make you go one direction or another?
That's a great question. And I would love for some of my colleagues in epileptology to weigh in. I'll tell you what my perspective is, and I want to hear what their perspective is too. For me right now, the science is unclear as to which is superior, DBS or RNS. There is some intuitive desire to go the RNS route because it's closed loop and it gives us some electrocorticography that we can follow and potentially act on. And I think that is enticing. However, DBS is attractive to patients who can't necessarily comply with the need to upload electrocorticography to the cloud regularly. And so the nice thing about DBS is that it's like that Ron Popeil rotisserie chicken, set it and forget it. That was an infomercial from when I'm dating myself, but that was an infomercial from when I was a kid. But the DBS really is set it and forget it because it's open loop. The battery lives are long. The complexity is low. We know it works pretty well, okay? There is a lot of work to do in the DBS front too. RNS, again, has the enticing nature of being closed loop, which means it can afford us potentially some benefit to modulation in the future as we continue to develop algorithms for interpreting the electrocorticography and how to respond to it. I'd say in present state, though, it really is a question. Sometimes it's a question of the payer, like which will the payer pay for? The payer pay for DBS or the payer pay for RNS? And those are the things that I like to think a lot about. I lean a little bit DBS because I think the data is pretty strong for both, but the thalamic neurostimulation is compelling in DBS. But I'm open to both and pretty agnostic as to which could be better than the other. Does anybody else have any thoughts they want to share on that? I'd love to hear your thoughts.
Hey Jay, great question, Michael. It's often what we discuss every week at epilepsy surgery conference. If somebody isn't a resective or an ablative candidate, which form of neuromodulation do we think might be best? And as Jay was saying, there's very little science behind making that decision, and unfortunately, no way to a priori predict who's going to respond well to neuromodulation or not. Um, there are some factors, though, that clearly drive the decision. Obviously, we're, you know, only able to offer neuromodulation in young children with VNS therapy. RNS and DBS are FDA approved for 18 and older, although we've been very successful with both therapies and getting them approved at a younger age, but it is a challenge. And VNS is FDA approved at 4 and older, although we have many patients that are 6 months of age. It's unlikely, based on current generator size, that it would be able to be used for RNS under 6 years of age. The youngest patient is 6 years of age. And the generator for DBS is pretty enormous compared to the RNS and VNS generators. So that also has a limit on body size. The other thing that influences the decision is ongoing brain imaging. So there's no limitation for brain imaging with VNS, but if you have wires in your brain with RNS or DBS, there is a limit to to radiofrequency dosing with MRI. So if somebody had something like tuberous sclerosis that needed regular MRI following of an expanding SEGA, or if somebody had a cortical dysplasia that was looking maybe had a neoplastic component, you might think twice about in-brain neuromodulation just because of the limitations of RNS. Just a couple of brief other thoughts. One of the advantages of VNS is the magnet, and our use of rescue benzodiazepine therapies goes way down once families can stop a seizure with a magnet. So that's a big advantage of VNS over RNS and DBS. And the other advantage of RNS is the long-term EEG monitoring. So if you have bitemporal lobe epilepsy or bifrontal lobe epilepsy, and phase 1 or phase 2 monitoring suggested seizures coming from both sides, so they weren't thought to be a resective candidate. But after a year or 2 or 3 or 4 of monitoring, you realize that the vast majority of the seizures are coming from one side. That could lead to consideration of surgical intervention to stop the most active focus. And here we have about 30 RNS patients. We're one of the largest numbers of pediatric experience in the country. And 2 of my patients have gone on to have resective procedures after showing that the vast majority of their seizures were coming from one of the 2 foci that we were monitoring. One was a frontal lobe and one was a temporal lobe. So
Thanks. I guess those are great thoughts. Thank you for sharing them. You know, interestingly, what Angus was just mentioning, which I think is worth exploring, is the idea that RNS can be like an ambulatory phase 2. And I love that as an idea. I would say that in practicality, we talk about it a lot. You're a little limited, right? Because you only have 2 leads. So obviously it's an ambulatory phase 2 of only 2 foci, right? Two leads. But it is an intriguing idea that moving into the future, that is going to be a reality. I think particularly as more devices come online with multi-channel, multi-lead capability, I think that there is going to be a future in which we are going to be implanting for ambulatory phase 2. I think that is absolutely going to be happening in the next 10 years. It's just that we're a little limited right now technologically, but I think that's there. Any other thoughts, guys?
Well, just to quickly follow up on that, I would find that very intriguing about the ambulatory, phase 2 aspect of the RNS. And I'm curious if you found the DBS with its chronic sensing capabilities can give you similar data where it would be valuable in that regard, or if you think the RNS, at least for the epilepsy indication, is clearly, ahead for that particular use case.
So I tell you my perspective, and again, I'd love to hear Angus's or anybody else's perspective too. Right now, the power spectrum analyses that Medtronic provides from the Percept, it's really unclear exactly how to use that in the context of epilepsy. If you look at some of their data, particularly, I want to say it's like their alpha and beta band activity seems to correlate with efficacy. And I could be messing that up, but that's the last time I saw their data. That's what I remember, like what's sticking out in my mind, what I remember. It's not really, I think, quite the same as surface electrocorticography or depth electrocorticography. It's a little bit different. And so I think there's very encouraging data that suggests that, I want to say it's beta band, that there is a modulation of beta band that occurs. It seems to coincide with efficacy, seizure reduction. But I think there's still a lot of work to be done there. And it's not quite the same as like a phase 2, right? You're just looking at a power spectrum. But that's been my experience with DBS.
Yeah, and it's not localizing or even lateralizing like RNS is. So you're just looking at power spectral analyses and trying to decide on treatment parameters for DBS to guide your programming, but it doesn't in any way localize where the seizures are coming from, like RNS does.
Any other questions or thoughts, guys? Well, I wish you all a great day and a really happy new year. And thanks for a great year. And 2025 is going to be an even better year. So have a great day, everybody.